Welcome. This is the LMICS Annual Forum for 2021. My name is Anna Hedigan and I'm Project Manager at LMICS. We've got a really good program today, so I'm just going to start us off pretty much on time. So I'd firstly like to start by acknowledging that we're meeting on Djadjawarrung country and pay my respects to the Djara people who are the traditional custodians of the land that we meet upon today. I'd also like to pay my respects to elders, both past, present and emerging. Thank you for coming. It's an unexpected benefit of the global pandemic that we're now so able to meet online and share knowledge and ideas with more ease than we did before. And while we've loved the networking and interstitial conversations we've had in the past at our LMICS annual forums, we're very happy to be able to offer three wonderful speakers today on the subject of geriatric oncology and collaboration in care of the older person with cancer. I'm sure there'll be a lot of questions prompted by these presentations, so I encourage you to use the chat function to pop in questions as they occur to you. And then we can pull them out at the end of the session, towards the end of the session, and ask our panel to answer them. Okay, so older patients referred for cancer treatment may have complexities in care relating to their comorbidities, frailty and social settings, but there's huge variation in this and one size does not fit all. Individual assessment across multiple health domains within oncology using models from geriatric assessment can inform decision-making, reduce treatment-related toxicity and morbidity, and minimise unnecessary healthcare use. Currently, MedOnc and RadOnc are trialling 3 prompt questions for new patients in the supportive care screening tool to flag potential vulnerabilities for further investigation. This means frail patients with complex comorbidities can then be selected for comprehensive geriatric assessment. I'd like to introduce our first speaker. That's Dr. Mark Warren. He's medical oncologist here at Bendigo Cancer Centre since 2008. With monthly visiting clinics to Groningen District Health and Swan Hill District Health. His special interests are genitourinary oncology, upper GI and thoracic oncology. Thank you, Mark.
Thank you. I shall just share my screen here. So I think, I think we're right. So I'm I've called my talk Why Geriatric Oncology, because I thought that I would kind of share just some of my perspective and why I think it's important, and why is probably related to some of the mistakes that have and some of the bad outcomes that happened pertaining to older patients. So here we go. I'll just see if here we go. So with an aging population, this is a more common problem. I just went through, in fact, last night I just went through our new patient bookings for the last 3 months, and 28%, so 39 out of 140 patients newly booked in for systemic treatment were 75 years or older, so that's 28%. So it's quite a high proportion of our patients being treated in the older age bracket. And in fact, technically, the elderly population is actually above 65, so probably more like 60% of our patients fall into that category of above 65. And I think when we assess elderly patients and their fitness for treatment, we're good at the extremes, so the really fit ones and the really frail ones, but we're not very good in the middle. So, a bit of a case study. So early on, when I was working at Bendigo, I saw an elderly man who had been referred for adjuvant chemotherapy after having surgery for colon cancer, and he would have been in his 80s. And I've got a picture of an elderly gentleman on a bike, because I remember that this guy used to cycle and he was really fit and he didn't have much obvious comorbidity. And I thought, you know, he was about as good as I get for his age. And so after discussion about options, we elected to pursue adjuvant chemotherapy with capecitabine, which is an oral 5-FU prodrug, and that's probably one of the more, we think of it as being the more gentle regimen for colon cancer, but occasionally people get sick on it. So he had the first cycle and he went really well. And then in the second cycle, it all fell apart. So he came in with diarrhea, which is a fairly common problem with this chemo. And that in and of itself probably shouldn't have been too much of an issue. We gave him IV fluids to rehydrate him. But of course, he went into renal failure. So his kidneys were probably not as good, and he went into acute renal failure as a result of being hypovolemic. And then he developed a delirium, and he had the full-blown delirium. It wasn't, it's the delirium where the nurses are just tearing their hair out trying to manage this guy. Just agitated, getting up and around, and just not, so it became really challenging from a nursing perspective. And then finally he aspirated in the context of delirium. And perhaps he'd been given some medication just to settle him. So maybe that made him more prone to aspirating. But before we knew it, it was multi-organ failure. And he ended up dying from this. So and I remember reflecting back on this case and kind of realizing, well, actually he seemed really fit at the start, but there was no reserve. So as soon as something went wrong, he didn't have the physiological reserve to deal with the side effects of the treatment I was giving. And so that probably that story and other cases like it has been the trigger for me to have a bit more interest in how do we look after these patients a bit better. In fact, just very briefly, there's another patient that came in last year who had advanced HER2 positive breast cancer, and she was on just a few biological treatments that are generally well tolerated. It was going along quite nicely, but she actually had dementia, and the husband compensated for her. And what really struck me was that it was really, people were aware of it, but it was really underemphasized in the documentation. Like no one ever made comment that this person had dementia. And we know what it's like. They turn up, they're not at all the right times. They seem to make sense. The husband answers some of the questions, and you kind of and you don't notice anything's wrong. And this lady had stereotactic radiotherapy when she developed cerebral metastases, and developed a full-blown delirium and was in hospital for a month. And it happened twice. So it really underscores how we're really failing a lot of these patients. So when I trained in medical oncology, the way we assessed fitness for treatment was the ECOG performance status. And I think probably most people have heard of it, but that's it there. And if you haven't, but essentially 0 is fully active, able to do strenuous activity. 1, you're a bit more fatigued. So you can do light housework and light tasks, but not heavy tasks. 2 is you're starting to become more unwell. You're sleeping less than half the day. 3, you're kind of resting most of the time. And 4 is bedbound. And in general, ECOG 0 to 2 are suitable for treatment. 3 and 4 generally don't get benefit. And so that was how I always used to assess whether someone was well enough for treatment, and we still do. But I think we've realised that in the aged care population that's not adequate, and we're missing aged care syndromes and things that doesn't pick up. So when I see an older person now, and I'm thinking of giving them treatment, I do a few things that are a bit different. So one is if they're getting chemotherapy, one of the things that I will often use is a CARG calculator. And this was a study that used a whole lot of geriatric domains to try and identify who might be more vulnerable to getting sick on treatment. And there's little sort of calculators online that you can use to calculate it. And in fact, there's an app that I use on my phone for it. So basically what they found was that they did a whole lot of, univariate to multivariate analysis, and they came up with a bit of a model of things that make someone more likely to get sick on treatment. So it was age above 72, if you had gastrointestinal or genitourinary cancer, if you had full dose chemo as opposed to dose reduced chemo, if you had a couple of drugs rather than one drug, if you're anemic, had some renal impairment, if your hearing wasn't that good, if you had falls in the last 6 months, if you were unable to take your own medications, if someone else had to help you with that, couldn't walk a block, or if you weren't getting out and being social, which I guess in the pandemic, that one's a little bit harder to score, but you'd come up with a score, and if you had scored 0 to 5, then you're probably doing okay, and your chance of getting severe toxicities 30%. If you have between 6 and 9, it's 50%. So that's grade 3 is normally side effects that would be bad enough that it might land you in hospital. Grade 4 is life-threatening, and 10 to 9, you've got a really high chance of getting sick. And what they found was that if you just use performance status, and the KPS stands for Karnofsky performance status, which is kind of more or less the same as ECOG, you didn't do very well. So that's one thing that I use now to help define suitability for treatment. Often I'll use another model, and there's a whole lot of them around that you can use, and I don't think it really matters which one you use. And I think a big factor of it is just that you're thinking about it. And I think as much as anything else, whether you use the Geriatric 8 model or another one, it's the fact that you're asking questions that make you think about other geriatric type problems that we don't normally think about that counts. So this is just an example of another one that you can use, where it looks at food intake, weight loss, mobility, cognitive loss, body mass index, number of medications, etc., and you come up with a score. And depending on the score, it would suggest that maybe they need further assessment, which would be that sort of comprehensive geriatric assessment. So if I get someone a bit frail, they're the things that I often do. The 3 screening questions, I kind of see that conceptually. So every time someone comes in for chemo or for an oncology appointment, they have their little questionnaire they fill out in the waiting room, and there's going to be 3 questions, which, medications, falls, and whether they've got a support person. And I kind of see that as being more just like a bit of an alert, an alert that someone needs a bit more assessment. And then the second stage would be something like what I've just shown you. And then the third stage would be a geriatric assessment. Another thing that we can use, there's a prognosis calculators. And so there's one called ePrognosis. And what that does is it's kind of asking the question, how long would this person be likely to live for if they didn't have cancer? So occasionally you get someone, like you might get an 80-year-old, and they turn up with, I don't know, something like diffuse large B-cell lymphoma. And that's a cancer that we can cure potentially, but we have to give them fairly intensive treatment. So it's like we have to make them really sick for 3 months to try and cure them. But of course, if their chance of being alive in 5 years is only 30% because of other comorbidities, you might start to question, am I really helping this person by trying to cure them, when in all probability they'll die of something else fairly soon anyway. So that's another thing that we can use to try and estimate, how long would this person be likely to live for if they didn't have on treatment, particularly in a context where the treatment might have the potential to cure them. So in other words, it's kind of like saying, is it worth me putting you through all this pain and suffering to try and give you more time at the other end. So it can help that way. So they're the kind of things that I'm using now. And hopefully by doing these types of things, we're going to better match the treatment to the patient. And in fact, I've written down some of the outcomes. So it might enable us to change treatment decision as to what we treat them with. We might lower the dose, we might change the regimen. We might choose to push on with the same treatment regimen, but we might at least consent them more accurately and say that, look, you're at high risk of getting sick on this treatment. At least they're informed. We can try and maximize social supports. So if we think that someone's got a high chance of getting sick, it might be that their family become more engaged to support them. Prehabilitation, so we might look at sort of, some allied health input to try and a bit of a quick pre-season before they start treatment. We often don't get time to do that, but we can get the ball rolling, and in some cases an aged care referral for a more thorough assessment and management plan. And we can redirect resources. So we have a CERT clinic, which is Symptom and Urgent Review Clinic. And if we can anticipate that someone's likely to be at risk, we can sort of redirect it and make sure that they're getting regular phone calls to really check in on them and make sure they're going okay. So that's from MedOnc perspective, where I think we're at the moment. So thank you. I think that was my last slide. Yeah,
great. Thank you so much, Mark. That's wonderful. If you could just stop sharing your screen. So I can get our next speaker along. Okay, so I'd like to introduce Dr. Jenny Wood. She's a consultant in geriatric medicine at Bendigo Health with a special interest in geriatric rehabilitation and pain management. Thank you, Jenny. If you just want to start sharing. I think you might be muted. Lovely. Yep, we can see that now. Thank you.
Jenny, are you speaking? I can't hear you. Are you on mute?
On mute. Here we go. There we go. So everyone can see my screen. I'll just put slideshow on. Okay, so I want to talk about, just follow on from Mark. I've been a member of the working party that between oncology and subacute services, looking at geriatrician input. Oh my God, hang on. But at how we can assist optimising cancer treatment outcomes for elderly people, particularly those who are frail, cognitively impaired, or suffering from other significant medical conditions. And the aim is to identify risks and optimise management for this vulnerable group of people. There were practicalities though, because we all agreed that there would, under certain circumstances, a comprehensive geriatric assessment would be a good idea. Trying to deliver this was a problem because we needed to be timely. These people can't wait on a geriatric waiting list for 3 months to be assessed, and it needed to be streamlined. And we also needed the resources to do it. So we really needed to also think about how we were going to fund it for the personnel. So it's time, money, resources, and also appraisal. There's not much point doing this if it doesn't actually add value, even though it looks like it should. So Associate Professor Budge and I have been involved in setting up access, and we've done this through an existing program called Geri Connect. But what we've done is develop a fast track pathway. And this is a flowchart for starting with oncology. And, you know, our oncologists actually do wonderful assessments and really screen out a lot of people to start with, you know, using the kind of tools that Mark presented. But so then if the oncologist feels a comprehensive geriatric assessment would be a good idea, a referral sent addressed to Mark Budge via Geriatric, and then in Geriatric, they triage it in several ways. It could go primarily for a kind of fast track memory clinic assessment, and it could go to one of the other geriatricians who does Geriatric for a more global assessment, and it may be more appropriate to come via me. So I want to tell you, once again, I'm going to give you a case just to illustrate. This is actually someone that's gone down this pathway that we're just bringing into place. He's Mr. A.B. He was 76 years old, squamous cell carcinoma of the lung, and my registrar and I saw him just after he started radiotherapy, so he actually was already in the pipeline. But he has got a few other factors in his background. He's a vasculopath. He's had a stroke. He's got peripheral vascular disease. He's had ischemic heart disease with stenting, and quite severe kidney failure too, and as well as other things. So who is this man? Well, there's quite a bit to him. He was raised in an orphanage. He left school at 14. He did various labouring jobs. His wife of 50 years had died, and also two of his children had died, and the third had cancer. He now has a disabled partner for the last 6 years. He was a very heavy smoker, and he was a very heavy drinker. And he actually quit both in January because he got a cancer diagnosis. He was walking with a single elbow crutch. We asked a lot of questions. He'd made a will, but he didn't have any enduring power of attorney or advanced care plan. And he actually comes from a town out of Bendigo, but he was living in Bendigo whilst undergoing radiotherapy. Okay, one of the questions I often ask patients that I'm seeing, to cut to the chase a bit to make sure I address what's worrying them, is, well, what's worrying you most? And it wasn't his diagnosis of cancer. He did comment that his lungs seemed to be getting better, and this was before a significant amount of radiotherapy, but it was probably because he'd stopped smoking. His main problem was his mobility. He was having lots of near falls. He had pain in his back, into his right leg, and in particular his right knee. And he had neurological symptoms in his right leg, patchy numbness. He'd actually been seen by the Alfred Hospital regarding back surgery, which they said was too risky. He had some pain relief from pregabalin, which is a drug that's used to treat neuropathic pain. Wasn't able to tolerate narcotics. He'd never been seen by a physio for his mobility issues and his musculoskeletal pain. So, well, I'm just going to go through the main examination findings. He was a real character. He was a bit tangential. It's hard to keep him on track with our interview. Whilst he did not have significant postural hypotension, i.e. a drop of 20 on 10, his heart worked a bit to keep his blood pressure up to 17 points under his lying pressure. So you wonder whether he does have some postural hypotension at times. He was walking quite well, but he was clearly limping on his right leg. He was a bit flexed over and was using his forearm crutch. He had evidence of neural tethering on examination of his legs, and sensory loss and basically an L4 distribution. And the weakness he had in his leg would correspond with that too, in that he had weak right knee extension. There's also the knee itself tested like one with some arthritis. It was a bit swollen, and joint line tenderness. We looked for depression and didn't find any. He had a geriatric depression scale of only 2 out of 15, and there was some evidence of cognitive impairment with mild cognitive impairment with an MMSE of 25 on 30. I have no idea why that's happening. Okay. Our recommendations following this assessment, well, firstly, the cancer diagnosis actually had a very positive turnaround effect on his general health. He clearly had a pretty awful diet, and he had, in fact, also changed that around as well. And that all needed support and encouragement. He was managing in the community. His partner being really disabled meant that there were lots of support services going in for her, and they supported him too. One point was that his educational status and the fact that he had some impairment on MSE makes you think that he really would need very simple, clear explanations of what his treatments were about and what his options were. And more than that, you need to check to make sure that he's actually understood what he's been told, and then probably give him written information because he may not remember it all. Overall, though, I think he probably was more going for him than perhaps his educational status might have indicated. He was on a lot of medications, but really you couldn't argue. I mean, there was nothing to suggest that they were ones that you should immediately cut. Maybe with his lifestyle change, he wouldn't need so much treatment for his cholesterol. We spent some time talking to him about the importance of having powers of attorney and perhaps making an advanced care plan. And he understood this and was enthusiastic about seeing his solicitor and also his GP to discuss an advanced care plan. Really, he had quite a few musculoskeletal problems and a high falls risk, and he'd never seen a physio. So while he was in Bendigo having radiotherapy, we offered him outpatient rehab aimed to reduce falls risk, reinforce good patterns of self-management, and further assess his cognitive status. So he really had a little bit more impairment, particularly with regard to memory, than perhaps the MMSE was showing. But he was capable of learning, and he was very enthusiastic about the assistance he was getting. We really needed to teach him how to slow down. He was a bit gung-ho, and that put him at risk. We also schooled him on strategies to manage a failing memory. Physio assessment more or less agreed with our medical assessment, and Mr. AB was started on a home exercise program and taught about things like how to get off the floor, how to get out of bed, etc. We took the opportunity to have a high-risk diabetic foot assessment, and he actually did quite well with that. And medically, we gave feedback to oncology and his GP. I actually have another appointment coming up with him, I think by phone in the near future. So he actually flew through radiotherapy, but he was really pleased. He no falls, and he was reporting that he was having a lot less near falls, no episodes of his knee giving way. He was enthusiastic about his home exercise program and doing it nearly every day, and was going to get his GP to refer him to a physio near home. We stressed education and continuing strengthening exercises. So in this case, our comprehensive geriatric assessment included global assessment, addressing non-cancer issues that were impacting on his function. And, you know, if you're having falls before your cancer treatment, it's quite possible that you are going to be made worse and come to grief when you're feeling frail and tired because of your treatment. Didn't happen in this case, but it was certainly worth thinking about. We reviewed his social supports, we reviewed his planning for his future, and we instituted multidisciplinary intervention to reinforce healthy lifestyle and management of his chronic conditions. And I think there was one other thing that happened with all of this was that instead of perhaps facing cancer with a sort of gloomy outlook, he was really energised, and we built on his decisions to do what he could to help himself. So that's one way that a comprehensive geriatric assessment can help. And that's the end of what I have to say. So.
Great. Thank you so much, Jenny. That's a fascinating case study and a wonderful segue in terms of the role of physio for that patient into introducing my next speaker, which is Janet Cobden. Janet's a physiotherapist with more than 30 years experience, gained through clinical work as senior physio in GEM, senior physio in transition care program, and chief physio at Bendigo Health. Currently completing a Masters of Applied Science Research focusing on frailty, published in the Australasian Journal of Aging. She's passionate about all aspects of frailty in community dwelling older people and is going to speak on that today. Thank you, Janet.
Okay, let's see if I can share my screen. One moment. And share. We right?
Yeah, it's coming up.
Yeah, lovely, just because I can't see. So yes, thank you very much for inviting me to this LMICS forum. It was came out of the blue, and I feel a little bit like both Mark and Jenny has stolen some of my thunder. But yeah, I do want to reinforce, I suppose, some of the things that both of them have said about the need to identify frailty. Not only in our general population, but in our cancer population. So the screen whoops, come on. Why aren't you working now? Enter. Okay. Oh, okay. I can't seem to move my screen. Oh, that's weird, isn't it? Let me just stop share for a sec. Sorry about this. And escape. Oh, lovely. My computer is frozen. Jolly. Very good. Okay. There we go. All right. Found it. All right. So if you look at the symptoms and signs that I've got printed there, they do sound very familiar.
We can't see your slides.
Oh, sorry, anymore. I've got to share again. Beg your pardon. Come on. Oh, goodness me. There we go. There. Now you can see what I'm talking about. Thank you for that. Yeah, so if you have a look at this list of signs and symptoms that you might often see in your cancer population, you look at them and it looks all very, very familiar, doesn't it? But in fact, these are the signs and symptoms of someone who is frail, either with or without cancer. And the thing is, now I got to try and move this slide again because the little thing is going. I might have to stop sharing and and go into it. Sorry. Stop share. What's going on? There we go. And then we'll share again. I'm sorry about this. I've got a little glitch. So just a very quick, and everybody here knows all about this, that, you know, if you're frail, you have increased vulnerability to all kinds of adverse events, such as Jenny's case with the falls and so forth. And the tricky bit, I think, for oncologists is that it can exist independently of age, independently of disability, and independently of disease. And this is kind of where it gets rather tricky. But the thing that we have to take into consideration is that the health outcomes for both frailty and cancer patients receiving treatment with, you know, surgery, chemotherapy, or radiotherapy are really closely associated, because cancer treatments increase those physiological stressors, and physiological stressors impact heavily on frailty. Because it reduces the frail person's, you know, ability to adapt, their adaptive capacity. So when looking at it in a study by Ethan called Frailty and Cancer, Implications for Oncology Surgery, Medical Oncology and Radiation Oncology, he reports that over half of older patients with cancer have either frailty or pre-frailty. And I think everybody knows that pre-frailty is hard to diagnose, hard to pick, but it is actually the early stage of generalized frailty. And then this study also showed that the incidence of frailty doubles in patients aged over 85 years. And as Mark was saying, they've certainly found that in their population. And also, as Mark said, is you can't identify frailty purely by looking at someone.
Janet, can I just check, you know, that we can't see your slides?
Okay, let's go here again. I'll share screen again. I clicked on that.
Otherwise, Anna, do you have them? Could you?
Yeah, I can share them. Yeah, I can.
Yeah, can you share them?
Yeah, I'll do it, and you just tell me which one you want me to be on.
Okay, so you just, that one.
Yeah, okay, I'll
Go
just
to
get us back
slideshow.
into slideshow.
Yeah, thank you, because I'm having real problems at this end. I do beg your pardon. Okay, forwards, not backwards, would be great. Okay, so one of the things that, because you can't tell people are frail just by looking at them, and Mark alluded to this, we need to do screening for frailty for people over the age of 65 at every single level. But the tricky bit is that your, you know, and there's a lot of discussion in the literature about this, is that your choice of assessment measure, for instance, Jenny doing a comprehensive geriatric assessment, isn't always possible. It's too time-consuming resources. And so you have to look hard at what outcomes you're looking for, and you have to look at what particular situation, you know, that you're in. The handy thing about frailty is, though, and Mark had a screening tool, is that you can either screen or do a full assessment. And most people in primary care and so forth start the process with a screening tool. And there's a lot of frailty measures that have been identified in a systematic review that resulted in a publication of something called the Frailty Toolbox. And I've put that reference at the end of my slides. So as Mark again said, fit for treatment, the best fit of a frailty measure kind of depends on the pragmatics of it, you know, where you're going to do the screening, when you're going to do the screening, and, you know, if you need particular equipment or you need particular resources to be able to do the screening. Next slide. So this is a cancer-specific geriatric assessment, which looks very much like the one Mark showed us. And I guess the reason I've brought this forward is that because if I asked you to picture in your mind someone who's frail, inevitably you would also picture someone who's old. But we have to remember that frailty is present in younger people as well, who have cancer because they've got that generalized physiological decline that we associate with frailty. So Mark uses a two-step approach, and it's something that most oncologists do, using a simpler frailty screening measure. And there's a bunch of them out there. I personally, as a physio, quite like the 5 criteria phenotypic measure by Freed. It's nice because it incorporates strength in your hand, your walking speed, your energy levels, your nutrition level, and your ability to get up and go, I guess. So it's a nice, easy one, and anyone sort of with 2 or more on that is considered frail. Then you refer to this more comprehensive, and obviously Jenny's involved in that project, but you need to remember that not everybody does need a comprehensive geriatric assessment. In fact, if you use the Frail scale, F-R-A-I-L, which stands for ambulation and illness and etc., that's quite a nice one, which has about 12 questions that can be answered subjectively and gives you a much clearer picture. And in using this particular cancer-specific geriatric assessment, it was really useful because it leads a referral pathway. So it's quite important, as we know, to consult with your social workers and your financial counselors, etc., your physios, because, you know, the lifestyle or functional impacts of cancer and cancer treatment is really important to offset. The Vulnerable Elders survey with 13 questions was particularly good in women with early breast cancer. And SMETS measured over 70% sensitivity and specificity in measuring frailty using the Groningen, which I'll show you next, frailty indicator. So it's not, you can't really use a one-size-fits-all either measure to determine frailty in all your cancer patients, which I thought was really quite interesting. So it may, in fact, depend on the type of cancer being diagnosed. Next slide, please. Mark touched on this because once you have determined that someone is frail, how severe their level of frailty is, and how at risk they are for the impact of adverse events. Once you get to that part, that, as Mark said, helps you determine, you know, what kind of treatment pathway you're going to follow. And obviously, this determination of fitness for surgery varies between cancer surgeons. And unfortunately, it's often a very essential component for cancer treatment. And when you are considering surgery, you really have to consider the impact frailty will have on their long-term morbidity and mortality outcomes. So, for instance, I worked with a lady once who had very early breast cancer and opted not to have any therapy at all because she was so close to feeling that her end of life was near. She wanted to do that with as good health as she had from her current management plan. So that took a little bit of negotiating, I guess, on the part of the team to bring that to home. One form of geriatric assessment for frailty is called a frailty index. Now that's a fairly sizable tool, and it measures the potential for post-operative complications. It measures discharge destination. It measures mortality and is quite specific to thoracic, abdominal, gynecologic, and general surgeries. If you wanted to check, Ethan, and I've cited him at the end of my screens, cites 13 research papers describing adverse surgical outcomes associated with frailty. So it's not that you just get a bit slower. It's not that you just sleep a little bit more. A lot of nasty things can happen if you go through with the surgery. And we often do see worse post-surgical long-term and short-term survival. When you look at chemotherapy, I think we really do have to educate our patients about what, the impact of frailty is going to have on their ability to cope with chemotherapy. Obviously, as Mark says, you take into consideration, their physical size, their general frailty, and you modify your dose. But, they are very much prone to chemotoxicity and to really poor treatment tolerance. So you really have to look at the total picture of the person, including the frailty, to dose correctly. And then the same is true with radiotoxicity. But that said, there's actually not a lot of research of frailty in radiotherapy. So it was nice that Jenny's patient did swimmingly with his radiotherapy, and maybe we need a few case studies around that. Next screen. So this is the Groningen frailty indicator. And what it doesn't show you here is that there are 4 questions having to do with morbidity. Is a little speller there. I didn't do that, but somebody else did. Let's call it mobility. There's one around the general fitness, vision, hearing, looking at their nourishment, their mobility, their cognition. We often see post-cancer treatment patients who have a loss of appetite because it takes so little in a frail patient to turn them off their appetite. And often these patients get lost to the system and don't have an opportunity to regain their post-cancer nutritional status. And this one too has strong indicators for when deciding whether you need ongoing referral and ongoing treatment. So next slide, what we're looking for. Next slide. There we are. I don't know any of these people. The other ones were my mom and dad. Is that we need to really routinely screen for frailty in most of our patients, if you're working with geriatric patients. And we really do need continued efforts and interest by the likes of Mark and Jenny to identify frailty and have that incorporated into training of young doctors. And we really need to promote the multidisciplinary side to really help, as Jenny did, to really help tailor a more individualized management strategy and to really optimize care. So we need research, particularly in the radiotherapy side of things, to look into which measure to use in a specific condition would really help to inform practice for everyone who's involved in practice. So next slide, please, which is just my references. Not comprehensive, thank you very much, because I didn't have time to do nice comprehensive ones. But that's the end. You can take my slides off now, and we can go to some questions.
Great, no worries. Thank you so much, Janet. That's fascinating. Right, so if I could just remind everyone, we've got a little bit of time left to just pop your questions into the chat. Alana Solo, who's just Strategic Manager at LMICS, is just going to give us a brief review of our activities for 2021, and then we'll hit the questions. Thank you. Alana, you're on.
I hit the wrong button as well to share my screen.
Yeah.
Oh joy. Okay, here we go. So from the beginning. No, I've done the wrong one. Sorry, I've just got a few versions of this open and one of them won't let me edit it. How about this one? Yeah, so hi, I'm Alana. I'm probably looking at the list of things. I probably know most of you that are here. Why is that slow? I click to exit. Why is my slideshow started at the end? Oh, okay, so thanks everyone for being here. I'd like to just acknowledge the traditional owners of the land, and we're all over Victoria, and so there's lots of those traditional owners, past, present and emerging. I'm just going to do a little bit of introduction to the VICS, which is the Integrated Cancer Services as a collective. We've been doing a lot of focus this year on how we work together as a state, and just have a look at some of the projects that we've been doing. So we are Victoria's Cancer Service Improvement Network. We were established in 2005 and we are funded by the Victorian Department of Health. There's 3 metropolitan and 5 regional ones, and we call ourselves VICS, or VICS Loddon Mallee at the moment, and we used to be LMICS, but now we're VICS Loddon Mallee. This is our region, and a lot of you will know this region quite well. Some of you may not. It's 26% of Victoria by volume and by area, and about 300,000 people. And they're mainly clumped around Bendigo, but there's a reasonable amount of people up in Mildura as well, and then down south. These are the priorities for the VICS. So this is what we're all collectively working on. So all of the smaller projects you see will fit into this VICS wider plan. So it's improve equity of access to high quality cancer care, support the effective implementation of the optimal care pathways, and improve wellbeing and support for all Victorians affected by cancer. Today's talk has been around care of the older person, and that has been a project that we've been working on with Mark, really Mark's leadership getting it going years ago. I just want to put out a little shout for Mel Loram in our team, who's also been working on this project, to really see what can we do within the very constrained resources in both the Cancer Centre and the geriatric team that's going to have a meaningful difference. And what we might come up with might not be meaningful, but we hope so. And we're having a little test of these little questions and the pathway. So we're doing different work across these priority areas. Multidisciplinary care will involve the MDM software. Optimal care pathways cover the whole spectrum of the cancer journey. So everything we do technically fits into them. And we've been looking at lots of different small and large projects. We really try very hard to make sure our work is spread out across the region. And I would also say, in terms of optimal care pathways, we've actually funded a little bit of work for Aboriginal and Torres Strait Islander optimal care pathways as well. So LMICS itself, we're leading telehealth models of care, MDM quality framework, and survivorship care. So how we set it up now in the ICS is that one ICS will lead a body of work. Southern Metro ICS is leading the care of the older person body of work. What we bring in LMICS, and I want to say this to you so you can all think about how we might be able to work with you if you've got an idea for a project. We have got a partnership model. We actually really do know most people working in cancer in our region, even though there is a bit of turnover, so we don't know everybody, but if we don't know you yet, give us a shout. And those relationships are crucial for how we find projects that are going to have meaningful change. We do have data analytics. We've got a strong data team. The department kindly gives us some of the data from the region, and we also spend a lot of time looking at your records to support your projects. And then we've also got some funding from the department, and sometimes we get grants and other funding. And also we have what I would say is leverage, which is that we do have relationships with the cancer branch, and we have been able to do some work on advocacy and supporting them, and it's a mutual support. Here's some work we did last year and to do with COVID-19, which is obviously the topic of the month. So we did some work with telehealth, not month, topic of the last 2 years. We supported the telehealth in terms of understanding what was going on, in terms of the rapid, and congratulations to everyone who was able to rapidly move their patients from face-to-face to telehealth. We've been doing lately some COVID-19 scenario planning with the chemotherapy sites across the region, which has been very, very interesting. We've been trying to support just things like border control and patients flowing into our border from New South Wales. And I remember one terrible week, New South Wales changed the requirements 3 times within 1 week. And we had things like patients not knowing whether they could come into treatment and not knowing how to come back. So we've done a little bit of work on that. In terms of preparing for COVID, there's been some risk stratification of patients that have gone on, some protocolization, things like that we've helped with. And now we're moving, because of the urgency of COVID, we've been supporting projects in ED and hospital in the home as well. So we have been found to be a team that can be agile and can pivot towards the COVID effort. Everyone in the team is very looking forward to not doing that and going back to cancer as our bread and butter. This is a piece of work that I'm particularly proud of and I think is relevant to you all, which is that we've worked on a governance framework for the oncology services. Again, Mel Loram has been leading that for us. And it started with a piece of work where we interviewed and surveyed both Bendigo, which provides outreach to the other sites, to find what was optimal. We created a model of care, a model of care and a memorandum of understanding. And now we've been working on regular governance and also how to support that governance using some key performance indicators. So we've designed those, which I think is going to help as an enabler for all of our other projects. So if there's clear governance in a site, if there's a clinicians and clear information flow, then when you've got questions around optimal care pathway, there's somewhere for that to go. We've also done the MDM quality framework. Optimal care pathways, we've done some work on GP referrals. We established a GP oncology hotline, which is still going and still getting a few calls a week, which is great. And then we've also been supporting a skin cancer clinic to basically try and help improve the services for skin cancer. So get in touch with us if you want. We have a website which is pretty easy to find, and you can also sign up for the VIX newsletter, and you can find that through our website if you can't write that down. That's another way where you can find information about what we're doing. So hopefully that was useful and not too boring about LMICS.
Thanks so much, Alana. I know we're slightly over time, but I've got a good question. So I'm going to ask the panel before I wrap up, which is, it's for all the panelists. Does it happen often that you see a patient who you think shouldn't have been treated in hindsight? And what key factors are behind this?
Well, I suppose I can start. It happens all the time. Hopefully less often than it used to, with better aged care assessment and screening. Look, one factor is that I can't predict the future. So if I can have a tool that can predict the future, then that would be really, really cool. But I don't have that. I mean, I guess that we do shared decision making, and we don't always quite know how it's all going to pan out. You know, sometimes you get someone that you think should tolerate a treatment, but they fall apart, and other times you get someone where you're really worried about them and they sort of breeze through. So there's unpredictability even with the best model. You know, when it's a very challenging situation treating cancer, because sometimes someone will have a curable cancer, and so it's a really hard question to decide that I'm not going to offer someone treatment because I think they're too frail, and maybe they or the family are pushing for it. So sometimes you'll take the risk, and you consent them, and you go for it. Yeah, I guess we're all human, so even with the best model, we're not always going to get it right.
I think the other thing is, I mean, we are under no obligation to offer treatment that is futile. So we've got to be careful not to present things to people that we know won't afford them any advantage. But, you know, people who have capacity to make decisions, if they're fully informed, they can choose to make a bad decision. And I mean, sometimes you talk to patients, give them the scenarios, you give them the information, and they weigh it up and say, yeah, I'll go for it. And you know damn well it's going to be a bad thing, but I mean, they're making a choice too. So there's that side to it as well. You know, a bit like people who jump off cliffs and things. I mean, poor choice, but their choice too. Yeah. So
and I would add into that a lot of people accept frailty as just getting old. So introducing the concept of frailty, which can be treated, which can be prehabbed, which can be effectively turned back. Well, I'm hoping, because I'm actually frail at the moment for other reasons, that, you know, it might be the first they've heard of it too. So you've got that double-edged sword. Not only are you saying, you know, you're too frail for surgery, and that's the first they've even thought about being frail. You know, oh, the doctor said I was too old. Well, no, I didn't, you know. So it's very much a two-edged sword.
I think sometimes just having the honest conversation, though, sets you up for if things do go badly, because, you know, if you express concern that they might get sick on treatment and you're not really sure that they're well enough for it, but they really want it and you offer it, they're often a lot more accepting of things when it goes badly. So it often does help to make that transition to the care that's required when it falls apart. So
yeah, for sure.
We've just got one more question. Given frailty cannot be noted by just looking at someone, should a frailty assessment be included in all new assessments, as is mandated with the elderly falls screening tool? Or, hang on, sorry, I've just lost the last half of the question. Or maybe is this happening with oncology due assessments already?
I think in an ideal world, we would have some kind of allied health or nursing position to quarterback aged care assessment in oncology, because as a clinician, if you're running an hour late, you often don't take the time to do that screening tool. But at the moment, we don't have that. And so the oncologists are sort of doing it where they can to varying extents. I'm hoping that the screening questions act as a bit of a red alert, and if it hasn't been done by the doctor, that nursing staff and other people involved in their care can, you know, there's no reason why it should have to be the medical oncologist. I mean, anyone can do it. These are simple tools. The patients can do them themselves. So if for some reason it's been missed, other people can do it and then flag it back to the medical oncologist to say, hey, this patient that you're giving treatment to, I did a VEST 13 or whatever model, and they're actually really frail. You know, feed it back to us. So it's an imperfect system. Unfortunately, we don't have as much money as we'd like. We would love to have positions that we can't afford, and so we're trying to make the most of what we've got.
Alana, you just muted yourself.
Someone has put up in the chat also the CERC service. It can also support that, so that could be another consideration.
Well, that's wonderful. Thank you all so much, our speakers, for contributing your time and expertise to present to us today. I appreciate it very much. And I can see that 2/3 of our audience have stuck with us well past the 2 o'clock mark. So thank you to everybody who attended today. I'd also like to thank the rest of the LMICS teams for support in preparing today, Chris Seidel for technical support, and our partners Levosig, the Loddon Mallee Oncology Special Interest Group, which, if today has been of interest to you, I'd highly encourage you to attend. It meets every second month through the year, and it's a great platform for sharing on cancer activity in our region. So thank you all very much for coming today. I hope you found it useful, and we look forward to welcoming you next time. Thank you very much.
Thank you. Cheery.